Thank you for the invitation. And so today we will talk about the thrombosis and the thromboembolic complication of the mechanical security support device, and I have no conflict of interest. So basically, when you look at the title, it has the thrombosis and the thromboembolic complications. Those are two parts, and each one is a separate topic. And when we look at the other part of the title, which is the mechanical security support devices, so we know that we do have the temporary VAD, the centromag and the electronics, and we have the durable VAD, the third generation nowadays in the market, and the tandem heart as well as the impeller. So we're going to talk about all of these in 15 minutes, and I don't think this is going to happen. So basically, the objectives for today will be the pump thrombosis, and we will talk specifically about the pump thrombosis in the durable VAD. So we will start our presentation as usual with an introduction, then we will talk about the mechanism of such complication, and then we'll move to the diagnosis, and we will touch base on the treatment. So first, thrombosis and thromboembolic complication is not uncommon, and the incidence, if you look at the literature, of such complication during the first year is between 4 to 9%. And initially it was thought that the complication is happening, when we talk about the thrombosis, it's happening between the impeller and the hosing of the pump itself. But in a matter of fact, the thrombosis can occur at any level of the VAD itself. So it can occur within the inflow cannula, and we call this a pre-pump thrombosis. It can occur within the pump itself, between the impeller and the hosing, and in this case the thrombosis will be intra-pump thrombosis. It can occur also at any level of the outflow graft or at the outflow cannula, and in this case going to be the post-pump thrombosis. And each one of these can be diagnosed differently, and also when we talk about the treatment approach, it's slightly different. Talking about the mechanism of the VAD thrombosis, so first we have to understand that these devices are not biocompatible. It was present in the axial flow pump, and even with the improvement of the mechanism in the centrifugal pump and the second and the third generation, we still see these kind of thrombosis, despite of which generation we are talking about. And even with the improvement and with the highly titanium devices, we still see the pump thrombosis happening. So is it related to something else? Probably yes, because it has to do sometimes with the implantation technique. This is why it is important to make sure that the inflow cannula is aligned along the axis of the mitral valve, not toward the septum, not toward the lateral wall. And interestingly, when you look at the literature, that even with taking care of implanting these devices perfectly, sometimes the thrombosis happened and the misalignment occurred because of the continuous remodeling of the heart. This is why it's important to continue these patients on anti-failure medication and the remodeling modifying agents like ACE inhibitor, ARB, and the new guy Entresto, in addition to the aldosterone antagonist, even if they are feeling better with the pump. And we have to remember that heart failure syndrome is a syndrome, so it's basically a continuous state of inflammatory response, and even post-VAD implantation, these leukotrienes and cytokines are just playing around and causing significant activation of the coagulation cascade as well as platelet activation, causing the thrombosis to occur. Heparin-induced thrombocytopenia and clinical hit also has been implicated in such mechanism, and despite all the effort, still these are devices, these are metal. It will induce some sort of shear-induced platelet activation, and sometimes during the explantation, because of for heart transplantation, it's not uncommon to see a laminar, basically coating of a clot within the device itself. Acquired von Willebrand factor syndrome also has been described as a cause of such complication. And we have to remember our basic physiology. Varicose triad, if you do have endothelial injury or abnormal blood flow or hypercoagulability, all these factors may lead to thrombosis. And guess what? With VAD, you are going to get it all. Now we will move to the diagnosis part of our presentation. So pump thrombosis is critical, and diagnosis of such complication is important and crucial. We usually start by looking at the power consumption and the pattern of the power decrease. It can tell you a lot. So, for example, can tell you if the clot is gradually building, or if there is a sudden build-up of the clot within the pump itself, causing significant increase of the resistance, and increase in the resistance will basically necessitate the pump to use more power, so you will get a sudden increase in the power consumption. Or if the thrombus started to occur within the inflow cannula and then got ingested by the pump, so we will see some sort of a gradual increase of the power consumption. Or if it did cause significant occlusion of the inflow cannula and just basically blocked the inflow of the blood, so the pump basically doesn't understand what's going on. It just gives you what you give here, basically. So if there is no blood, no resistance, the power consumption will significantly decrease. So the pattern of the power decrease is important. So for example, in this case, you probably notice a very stable pattern of power consumption and apparently the flow, which is derived by the equation including the power consumption in hematocrit and the RPM. And then all of a sudden the power consumption and the flow decreased. So in this case, it was a pre-pump thrombosis caused this pattern. But the pump thrombosis doesn't present all the time with such presentation. Sometimes the decrease in the power consumption and the inflow can be insidious. It can sometimes develop over days or weeks, and if we didn't pay attention, a pump thrombosis can be missed. In this case, this insidious decrease in the power consumption and flow was associated with post-pump thrombosis, or thrombosis within the outflow graft. And acoustic analysis also has been described with a third harmonic as a diagnostic tool. Of course, the hemolysis parameters. But I should mention here that the hemolysis parameters may lag behind the start process of the pump thrombosis, and the hemolysis parameter, specifically LDH and plasma-free hemoglobin, may not significantly increase in case of pre-pump and post-pump thrombosis. And it's not uncommon that for these patients, their baseline LDH and plasma-free hemoglobin are basically elevated, but not too much elevated. So there will be no significant elevation sometimes in this parameter if we are dealing with pre-pump and post-pump. However, with intra-pump, it will be clearly significantly elevated for both of them, in addition to the haptoglobin and the bilirubin, of course, but specifically we are looking at the lactate dehydrogenase and the plasma-free hemoglobin most of the time. Assessing the LV loading condition as well as the clinical status are also crucial to diagnose pump thrombosis, and clinical presentation may really vary significantly. So the pump thrombosis may occur in the completely asymptomatic patients, in the ambulatory care units, and such patient may present, on the other hand, with acute decompensation and hemodynamic instability. So it's not going to take much to put a probe and check on the patient heart and how the LV function is doing. So with pump thrombosis, the LV typically will be overloaded, it will be ballooning, and the septum will be shifting toward the right. And you will notice that the aortic valve may open with each cycle. It just tells you that the blood is not going freely and smoothly through the pump, and in this case, pump thrombosis should be suspected. In addition to looking at the LV loading condition, assessing the pulse wave Doppler velocity of the inflow cannula as well as the outflow cannula with the systolic peak, and the diastolic nadir is also important. We're not going to go through the detail of that, unfortunately. Now we will move to the treatment part of it, and with respect to the treatment, I would like to say that when you look at the literature, sometimes whatever you would do, regardless, soft lysis, glycoprotein 2,3 B inhibitor, or use TPA or whatever, sometimes pump thrombosis is the only way to go, especially in case of intra-pump thrombosis or pre-pump thrombosis or a big clot occluding the inflow cannula. With respect to the outflow cannula or outflow cannula thrombosis, sometimes embolectomy or thrombectomy with stenting with carotid artery protection may work and save the patient from going for a pump exchange. So, for example, in this case, a first treatment of thrombolytic therapy was given, and then the parameters of the power consumption and the flow improved, and then basically it recurred again. Probably it got ingested and did cause significant spike in the power. A thrombolytic therapy was given, but after that it was gradually building up. So you know what, he went eventually for pump exchange. With regarding HIT2, clinical HIT2, if the heparin-induced immunization or thrombocytopenia was the cause, then an immediate pump stain should be carried out and no other option. And if you look at the literature, it's interesting to notice that sometimes they even using bivalirudin as the anticoagulation of choice, regardless of the HIT status. Even if the patient was his negative, they probably realize that getting a hit, even if it's uncommon, can cause a very devastating outcome. Unfortunately, when you look at the prognosis, even after exchanging the PUP, even after successful treating these patients, the prognosis is less favorable compared to the patient who basically had the VAD with no such complication. Now we will move and talk briefly about the thromboembolic complication of pump thrombosis, which is basically like any neurology-related complication. In case of cerebral thromboembolism, sometimes the ischemic stroke related to the emboli, which is showered from the thrombus, can cause devastating complication and big ischemic stroke with significant edema. So the risk of the hemorrhagic transformation is high. And this is why, despite that we know it's a thrombus related, probably aggressive anticoagulation should be avoided. Otherwise, if there has been hemorrhagic transformation, then you have to hold your blood thinners, and then you are really in trouble. With thromboembolism in the abdominal aorta or peripheral artery, vascular surgery service should be on board. And in case of thrombosis of the ascending aorta, emergency transplantation is the only option. Now, in this case, basically, if you look at the literature, with the new technique of implanting the outflow grout in the descending aorta, if you don't have a good contractility of the heart, you will basically lose the benefit of having a washing jet within the ascending aorta and the arch. And with infrequent opening or completely closed aortic valve, sometimes you may get a thrombosis to be formed in the ascending aorta, which is really bad. So the take-home message: if there has been any change in the power consumption, yes, there are benign causes of such issue. However, pump thrombosis should be always in the differential diagnosis, and pump exchange could be the definite treatment. And also I listed some further readings of interesting articles and references. Thank you so much.